Welcome to the NFP Podcast, where we explore the empowering world of natural family planning. I'm Amy Smith. Join me and my co-host Emily Appledorn each week. Together, we're here to dive deep into the science, the stories, and the spirituality behind NFP. Every week, we push back against the free love culture and advocate for a culture of responsible love, where intentionality and respect are at the forefront of family planning. Join us as we discuss everything from the practicalities of charting and fertility awareness to the profound impact NFP can have on relationships and communities. Whether you're new to NFP or a seasoned pro, our podcast is your go-to resource for honest conversations, expert insights, and real-life experiences. So grab a friend, settle in, and get ready to be inspired. This is the NFP Podcast.
Today, Emily and I sit down with Dr. Phil Boyle. Dr. Phil Boyle graduated with his degree in medicine from Galway University in 1992 and is a member of both the Irish and Royal College of General Practitioners. Dr. Boyle is a member of the Irish Fertility Society and is currently president of the International Institute for Restorative Reproductive Medicine. He developed NeoFertility in 2016 after 20 years of experience with nanotechnology fertility treatment. Dr. Boyle is the founder and director of NeoFertility. He is the co-founder of the Chart Neo Fertility app. He has helped over 3,500 couples achieve successful pregnancies after many years of infertility, repeated miscarriage, and failed IVF. Please help us welcome Dr. Phil Boyle to the NFP Podcast. All right, guys, welcome back to the podcast.
Hi, everyone.
Emily and I are really excited today because we have on with us Dr. Phil Boyle, all the way from Ireland. He's going to talk to us a lot about restorative reproductive medicine, all the great work he's doing under the title of NeoFertility. And they also have a wonderful app that we want to make sure to talk about as well, because that's a great resource for our listeners. So welcome to the podcast, Dr. Boyle.
Thank you very much, Amy.
Yeah, thank you for being here. Can you, let's start with just a little bit of background for our listeners, who you are, how you got to be doing what it is that you're doing. Did you always want to be a doctor, etc.?
Well, I'm a family physician, and I wouldn't say I always wanted to be a doctor. I very much wrestled with the idea of engineering before I finally settled on medicine, and my goal was to be a family physician. And while I was doing my residency as a family physician, I came across the work of the Pope Paul VI Institute and Dr. Thomas Hilgers and what they were doing with the Creighton model and nanotechnology. This was way back in 1995. And, well, I guess when I discovered that, eventually it became clear to me the only way I would be able to get the information that they had was to go and do the training course. So I flew from, at that time I was in Galway, I flew to Omaha, Nebraska, and started the first education phase in April of 1995. And when I discovered the work that they were doing, it was inspirational. It really was, on both a scientific medical point of view and also from a faith perspective. It ticked both boxes very well for me, and both aspects are really important to me personally, so that really mattered. And the second education phase was the following October, and I trained as both a teacher and as a medical consultant. I did their combined program so that I'd be able to implement it at home. And as part of that training, I took on 18 couples. 4 of them had fertility issues. A lot of them were my friends in Galway who wanted to use a natural method. So in fact, they were a lot of my inspiration to do this because they were keen to follow the church's teaching. And I discovered with my medical training, I didn't have enough information for them. So one couple in particular, when I was giving them advice about natural family planning, I said, well, if you do this, this, and this, it should work. And he said, hold on a second, should work or will work? Because there's a very big difference for us and it really matters. And so very quickly I realized I don't have enough good information to be able to advise you. So that was one of the big reasons that I went. And so lots of my friends who were interested at that time, there were a lot more active Catholics in Ireland than there are now, and they were quite keen to follow church teaching at that time. So when I went over, though, I quickly realized that I needed to do the medical training and the teacher training both combined, because I really wanted to treat couples with infertility. So out of the 4 couples I treated, 2 of them had success and 2 didn't. But one of them attracted a lot of media attention for being the first NAPRO baby born in Ireland at the time. And I just had completed my residency as a family physician, and this garnered national media attention at the time. And I had reporters contacting me and radio shows and whatnot. And before I knew it, I had a waiting list of 600 people who wanted this fertility treatment. And I was discerning at the time, should I stay as a family physician or should I do additional training and work as an obstetrician? And when I saw the demand that was there and realized that there's a lot I can do as a family physician, I figured, well, I think that's what I'm going to continue to work at. So I opened my own practice. It was in 1998 by the time all the training had finished. And I've been busy ever since. I haven't had a quiet day. And I've realized that from a family physician perspective, there are significant insights from a medical treatment point of view that we can identify and understand with the help of a fertility chart, timed hormonal blood tests, engage in a process of cycle balancing, and then give the couple that space to conceive. And even with very simple things, I had couples who were coming to me, they had been to Bourne Hall Clinic, the place that developed IVF, where the first IVF baby was born in Cambridge. Louise Brown was born there, and they didn't have success with them. And I found with relatively simple intervention, I was able to help at least some of those couples to get success with very simple medical treatment from a family physician. So I was quite cognizant and said, well, hold on. If you've gone to the top professors in the fertility world and the top leading consultants at the top clinics, really, I'm only a family doc. I'm not sure I can really help you. And people would say, well, can we try it anyway? So we went with that kind of a context and not knowing which way it would go. And thankfully then over the years, I was able to demonstrate that this just isn't a once-off fluke. We're able to do this repeatedly, and we've published papers to back that up. But it's still very, very difficult to get my peers to accept this still. And I thought 5 years and everyone's going to latch on to this. But I can't believe I'm approaching 30 years. And even by the time I catch on as much as I had hoped, who knows, maybe in the coming years it might really take off.
Or it'll be one of those things where in, the next generation, everyone will be like, can you believe back then that they did things like IVF? And, talking about it as such like an archaic, crazy kind of time. And they didn't try to like restore ovulation, and they didn't know about all these other methods. And I think about that sometimes in just daily life, right? It's like, wow, can you believe they didn't have crock pots or dishwashers or these things? And yeah, you kind of, you take for granted all the work that people have done coming before you, and then now you just get to live in an era where there's just really great, in this case, it would be, women's healthcare. So do you primarily work with patients?
To stick with that, because it's a really good point, Amy, sorry, that the insights that we're getting from the fertility chart, it's exactly that. I think it's getting to the point of medical malpractice for our peers who may not be philosophically in agreement with the inspiration behind all of this. And this is what we've done with neofertility. It's not that we've taken God out of it, because the faith dimension and my moral compass is really important to me, but it's not the first thing people see when they knock on the door, and they see science and medicine inspired by Catholic thinking, but applicable to everybody. But I think it's getting to the point where our peers who are our fertility clinics, if they attempt to evaluate and treat a fertility cycle without working with a fertility chart, for me, that's malpractice. Mm-hmm. And I think it's litigation that may ultimately drive them to say, we need to do this, because you don't need to be a practicing, believing Catholic to track your fertility cycle, observe the biomarkers, identify your day of ovulation, get timed hormone assessment, identify the deficiencies, correct and restore your cycle in a logical, systematic, methodical way. And you don't have to mention anything about faith, even though it's inspired by that. It's good medical practice. So it's got to that point, and where you'd say, because I would look at just like that point that you made, can you believe somebody attempts to treat fertility without a fertility chart? Can you believe how crazy that is? Because all of the information we can get, I tell people it's like trying to find your way around a new town or city without your Google map or some kind of a map on your device. I mean, you may eventually get to where you're going to, but you may not. And it's so much easier if you use these developments that have occurred.
Absolutely.
So I think that's a real good point. Yeah.
And I would go further to say you don't have to be Catholic to deserve to know all of that information. So many women and couples just don't even know how to, monitor basic observations. And that's really, they're interested in knowing that, I think, especially if they're struggling with infertility. They don't want to be just told that it's unexplained,
The irony of that, though, Emily, is that is Catholic. It is Catholic for us to help everyone,
100%.
to serve everyone, because human dignity, and you are made in the image and likeness of God, that goes regardless of where you go to church or don't go to church. That's just a fact that we believe. And I feel like that, sometimes it's like, but it's Catholic or it's not. No, but that is Catholic. The way that we live, the way that we approach this service to people is motivated. The why we do it, the reason for our faith, the reason for our work is because our great love for God. And to your point too, Dr. Boyle, sorry, Emily, I didn't mean to cut you off.
No, it's true. Like that is.
I'm not wearing my I'm Catholic name tag, but that's the reason why we're doing it, And I think to your point too, Dr. Boyle, is like, there's also multiple ways to evangelize. And so we can lead with God, church, Jesus Christ, all of the foundational teachings. And we can also point to him and lead to him through the good, the true, and the beautiful, and treating patients with profound dignity and respect. I mean, it is just amazing. I know Emily and I have both experienced this personally and anecdotally from working with women and couples, is just the profound difference in encountering a physician who cares about my cycle pattern, who wants to get to root causes, who's treating me just like a person and not like a cog on a wheel. It is profoundly impactful. I mean, it is just such a night and day experience. And I hear it all the time, regardless of any attachment to faith, just like, wow, this doctor sat and listened to me and took a real history and really took interest and wants to find out what's happening. And you don't get that when you go through the kind of IVF infertility mill, It's just like, oh, you're not pregnant. Here's some Clomid. Okay, you're still not pregnant. Here's this. Okay, you're still not pregnant. All right, now IVF. That's all I've got for you. It's like, wait a second. Yeah. Why is it the same treatment plan for everyone,
Yeah, the time-honored principles of medicine are you take a history, you conduct appropriate investigations, you establish a diagnosis, and you treat what you find.
Right.
So we're very much going with time-honored medical principles, but it's like in the world of reproductive medicine, it's like our colleagues have just kind of walked away from that. And it's because philosophically, we believe we are, as a result of intelligent design, we are not accidents of nature, and we are comprehensible. We can understand when things aren't working, why they're not working. And if we don't have all the answers, we keep on working in a framework of trying to understand what else could we be missing. And this is the beauty over nearly 30 years of practice now. When we would have a particular set of solutions implemented and we're not getting the right result, and we could clearly see, I'm missing something, what else could it be? And this is where it's led to us. So we started out with a good surgical workup. Dr. Hildress has always done a very good surgical assessment and good hormone assessment, very, very detailed hormone assessment. But that's not the whole picture. So now we've incorporated things with regard to diet and nutrition and lifestyle and exercise, which everybody does, but you really need to watch that you've covered that. Now we're looking at chronic infections, and the technology to identify and treat chronic infections has significantly improved. Very, very recently, in the last 12 months, we now have new techniques of assessing infection that weren't available to me a year ago. Mm-hmm. And that's really improving our success. Another big one for us is things like adrenal fatigue and low DHEA. I remember I had a lovely couple and we were watching her pregnancy, and her estrogen was incredibly low, and she'd few miscarriages before, and she went on to her about 16 weeks, and she lost her pregnancy. But I could see it coming because her hormone levels were terrible, and her obstetricians were telling her, your scan looks good. I said, we're in a world of trouble and I don't know how to fix this. Now, with the passage of time and carrying somebody like that in my heart, saying, Lord, what did I miss? What else? It's like, it comes to you, and chance favors the prepared mind. So your mind is prepared, you're looking for answers, but also there's a faith dimension where the wisdom of the Holy Spirit and inspiration, and say, let's try this, but you always do it under the umbrella of first do no harm. That's where we came up with DHEA. If I had that back then, we could have saved that pregnancy. I didn't know then, but I do know now. And we've since published a paper looking over 10 years of practice and the impact of DHEA treatment and the way it can further reduce the risk of miscarriage. So that's the beauty of it, that it's been an exciting voyage of discovery, trying to identify if we don't have a solution, and also admitting we don't know what's going on here, and trying to discover what these new things are. And there are things we tried that didn't work as well, but at least we've tested it, and we're trying to look under every possibility as we progress.
I think that's one thing I really admire. I know you're also, I think, correct me if I'm wrong right now, I think you're the director or president of the International Institute for Restorative Reproductive Medicine. So I just really value, I mean, I'm not a medical professional, definitely not a medical professional, but just as a patient, to know that there's great professionals out there in the field doing wonderful work, and then still translating that into research and publications to kind of continue to share that message with people. Because I don't know, Emily, how often you still get this. I still get this, though, in conversations I have, is somewhat of a little bit of a patient skepticism that, wait a second, if this isn't, IVF or IUI, and we're talking about infertility things, or the birth control pill to help suppress issues with, menstrual cycle problems, well, then is it a little like, hippie science? Like, is this real? And I just really love the level of professionalism that IIRRM offers, to kind of put that seal on it, to say, no, these are doctors that are practicing in accordance with human biology and physiology and trying to get the body to work as it should. And then there's research to support their, interventions and their efforts. So yeah, I just really admire that aspect of your work very much, that you're able to still see patients and do research. So you must never sleep, really.
I sleep plenty. I do well.
Oh, good. Okay, good. So tell us a little bit. I mean, our audience has heard this before from other people, but I'd like to hear your kind of take and perspective on it. What is it that, or how would you define, I guess, the term, restorative reproductive medicine, or and the work that you do to help couples achieve pregnancy? Because based on our conversation so far, it sounds like that's pretty much your primary population, is you are working with couples who are actively trying to achieve pregnancy and can't.
For the most part, exactly.
Okay.
So it's funny, because that's the question I ask. I train medical students, and that's the first question I ask them. So it's funny to be in the receiving end of it. And it's a good question, because a lot of our peers think they're providing restorative reproductive medicine, when in fact they're not really. And one of the key things that differentiates it is we work with the fertility chart. And I go so far as to say, if you don't work with the fertility chart, and there's multiple charts, you can work with the Billings chart, the Creighton model chart, symptothermal chart, the Marquette, and our chart is Neo-Fertility. And I just find with our app, it just makes it easier for me to work with clinically. But you need to have a chart, and you need to record the biomarkers of fertility. And that's the key thing that makes all the difference. And then you time your investigations and your treatment, and monitor the response of treatment based on what that fertility chart is telling you. So that's the key differential. And we look at both male and female. We go for medical, surgical interventions, and our goal is to identify whatever factors may be contributing to your subfertility, which includes both recurrent miscarriage as well as infertility. And the more things we can find and fix, we implement a multifactorial system of investigation, diagnoses, and treatment. It's rarely single issue. It's usually 3, 4, 5 different things all at the same time. And as you identify, correct, and that's why our view is that infertility is a consequence of multiple underlying chronic illnesses for the most part. And so it's a chronic condition. But the problem is, especially with IVF, that infertility is treated as an acute condition that needs a single intervention. And the problem is, if you apply an acute medical intervention to a condition that is chronic in nature, the results aren't going to be as good as you'd like them to. So that's so if you understand the condition of what fertility is, and chronic conditions need multiple and sustained interventions over a period of time. And here's the other thing that's hugely different is it's normal to take a year to get pregnant. So that's so important. So when everything is working fine, you're ovulating by ultrasound, you have a lovely looking chart, several factors have been identified and corrected medically and surgically, male and female, everything is right. Well, one of the worst things you can do is say, now we're really trying, the days are here, we have to try. Say, no, a baby is a fruit of your love, not your labor. So don't bring pressure, stress, intensity. This is competitive golfer mentality. It's not American football where we bring the intensity. You say the golfer is super competitive, but they have to bring a real delicate quality to it. Otherwise, they don't get the desired result. So we recognize how much we want the result and how much we want it quickly, but we recognize we can't make it happen. And the more we bring the intensity, the less likely it is to happen. So we make our peace with the 12 cycles and say, remember, enjoyable connection for you as a couple, alternate days during the fertile time is adequate, but let it be indicated by your chart, but decided by your heart, where you both have the freedom to say, I know the chart indicates, but I think tomorrow's a better day, and you support each other in that. That mentality is huge. And we see it all the time. When the pressure is off, there's a space there for pregnancy to happen. So it's really getting that relationship right in the midst of it all as well, and validating how crushing it is every cycle that passes. Birthdays, Christmas, New Year's, emotionally crushing times, and you validate that. Permission to shed the tears, express the frustration, but don't let it destroy the cycle. We're in process. We're not expecting it till July or August, so there's plenty of time there. So all those things are, yeah.
Sorry, that was just fantastic.
Yeah. Our colleagues just give up. Yeah, our colleagues just give up after 3 or 6 cycles, and it's just far too soon. You've got to let it run the 12 cycles.
Right. Well, not just that, just the way you worded everything. And in fact, it's funny, I was kind of expecting the same answer we've heard, a lot of times repeated, but you actually started somewhat uniquely to say the chart is what makes it different. Using charting, the charting pattern of the cycle. And it's just amazing too. People that have listened to our podcast know that we say this a lot, but the power that like our body speaks to us in that charting pattern. It is just one of the most mind-blowing things to me, like there's so much that can be identified from whatever pattern we may have. Even women who are like, well, I'm not ovulating, I don't have a pattern. Like, you got something, we got to map it out so we can see it, but there's something there. Those are just really, it's just so beautiful. Really well said. Thank you so much, Dr. Boyle.
The language of the body.
Go ahead.
The language of the body,
For sure. Yeah. And another thing that Emily and I totally agree with, and we talk about a lot, is, people who want to get pregnant want to be pregnant yesterday. And so you can easily, and we've both been in this scenario too, where you want to be pregnant yesterday and you get so fixated on that and you forget the strong bonding aspect of the marital union and how important that is. And it's hard when you're balancing the desire to have a baby and the marriage and the health of the marriage and that intimate relationship, how important it is not to choose one aspect of that act over the other, but to make sure they're procreative and unitive during that time. So yeah, it's wonderful.
I've got a good story.
I'd love to hear
that. So I had a couple very motivated to get pregnant. She was turning 40. They had 6 previous miscarriages, and they wanted to get pregnant as quick as they could because age was pressing on. So we identified, corrected, balanced everything, gave them the green light, and they used every single fertile day for 10 months in a row. And on their 11th month, they had a row on day 8. They kissed and made up for 1 day, and they got pregnant. So it was a very good demonstration of when they loved each other, they conceived, and when they had the stressed out chore, it didn't happen. So that's a good story that helps to make it tangible for people, and they can connect with that and say, okay, let's drop the intensity a peg or two, and that should help.
I love that story. I'm going to share your sports analogy as well with my husband, American football versus the golf.
I hate the golf. Same thing.
Yeah, I'm mentality American football, or rugby in fact is the one I quite like, but in terms of the sporting analogies help, but I'm not naturally in the golfer mode. I'm in the other, so I have to get my head into that space. But it's a good one. It helps people and it keeps it lighthearted. It's not heavy weather or serious or that, but it's good psychology. There's another point that I was keen to make before I forget it, because it's useful. And here's another fascinating concept with what we do. So the rest of the fertility world will tell you do not have a fertility problem unless you've been trying for a year or unless you've had at least 2 miscarriages. So here's the beauty of what we've got. If you're tracking your cycle and you've got your fertility chart there, a teacher who isn't even medically trained can look at the fertility chart and tell you, this is an at-risk cycle. I think you should see a doctor trained in restorative reproductive medicine to this, because an at-risk cycle is just that. It means there's increased risk. You can get away with it. And what I do find is the older women are, the more that risk will play out in terms of not getting pregnant or having a miscarriage or even a premature delivery. So we can see all these problems if you've got a short luteal phase, brown menstrual bleeding, limited mucus, very painful period, severe premenstrual syndrome. The teacher can pick up on all of these things. And it's massively useful information. So all of a sudden, you've a couple, if you say 1 couple in 6 are going to experience fertility problems. So a lot of them go on the pill, and then when they decide they're ready to try it, they go off the pill, they take their folic acid for 3 months, give up the alcohol, and they're good to go. We say there's a huge amount more you can do. And in fact, when you've made that decision to postpone having children, how do you know you're not going to be that 1 in 6 who has a fertility problem? Why don't you get a sense of what your fertility potential is, track your cycle? You'll have the same reliability as hormonal contraception, none of the side effects that would go with it, and you'll be able to get an insight into your fertility potential. And as you would know from the podcast that you do, when you exercise this periodic abstinence, it'll actually strengthen your marital bond. Your relationship gets stronger. As a result, your communication increases. It's really good for you. So there's so many advantages to tracking like that in advance. And so this idea where people say, oh, if you're going the restorative route, it's going to take longer. Say, no, we're way ahead of the game. We can identify an at-risk cycle before you try to conceive or before you've even had 1 miscarriage, and we can identify it, we can intervene, we can balance and get the best conditions for a healthy, successful pregnancy. It's more than just folic acid and giving up alcohol and a bit of exercise. There's a massive amount besides. And also, we can then reassure a couple and say, beautiful cycle, looking really good, these conditions are right. So we can also give them that confident reassurance. If they're not pregnant after 3 cycles, it's fine. And maybe after 6 cycles, we'll then start doing blood tests if it hasn't come their way. So that whole approach that we have, I think, is much more couple friendly compared to what's widely practiced.
Right. Yeah, I completely agree. I'd love to hear you share a little bit about, if you don't mind, some of your, kind of boots on the ground, anecdotal stories of working with couples who have come to you. I'm imagining couples come to you not as their first option, mainly they've tried something else and maybe come to you, but I could be wrong. So correct me if I am. And so I'd love to hear just, if you have a case off the top of your head or a couple of cases where it's been a challenging case. There were a couple, to your point, it's not just one thing. There's 5 things that are happening, and that maybe we're able to result with a live birth or maybe not. So, and that you use that neo-fertility method, I guess, specifically to neo-fertility. If there's something, is it just kind of similar to other fertility awareness methods, NFP methods, where you're charting the biomarkers, or is there something more specific? Is there something more you guys ask couples to do?
Yeah, so I worked with the Creighton model for 20 years, and then in 2016 I and developed neo-fertility, and it was 2018 we had our app with Chart Neo. And I've always loved the paper charts, and I'd say that paper speaks to me and I can see things and it tells me so much. But to my surprise, the app tells me a whole lot more, and people share it with me in real time, and it's completely secure. We don't share people's data with anybody else. It does all the HIPAA compliance in the US or the GDPR in Europe. So it's very secure data, not sold on to anybody else, and it's just between the physician and the couple. And if the couple want to switch it off at any time, they share it with their teacher, their doctor, and they have it themselves, but it's their own private data. But that sharing of it, it's a multiple index method where we look at mucus, we look at temperature, and now we look at urinary hormones. And urinary hormones have evolved. It's not just the LH test. You can measure urinary estrogen as well as LH, as well as progesterone, but it's more expensive the more things you do. So we use as few or as many of those indicators to identify, and our foundation is mucus. That'll work for us a good 8 times out of 10. But there's a solid 20% that I think do really well by adding in the other components as well. So that'll be the first thing. And then when people come to us, we get people at every stage. People who are just about starting to try because a friend put them in our direction, or they had a sister with a problem and they want to get on it straight away. Or then we get other people who are the wrong side of IVF with donor eggs that hasn't worked. And really, is there anything you can possibly do for us? And they said, well, friends told us and we thought we'd come and talk to you. So I had one couple in particular, they had 3 rounds of IVF with their own eggs. They had 2 rounds of IVF with donor eggs. And in fact, it was in the middle of COVID, and we were open during COVID, but a lot of the IVF clinics weren't. And they still wanted to press on. And before they did another donor cycle, they were kind of stuck. So I said, we'll try this because we want to do something. So they came our direction, and incredibly, with her history, so she was told that her eggs were of no value. But we investigated, and our app was key to the whole process. And we work with a treatment called low-dose naltrexone. It's an immune-modifying treatment that is a whole other separate talk that helps with PMS, period pain, and endometriosis. But she never had a laparoscopy, and she had significant period pain. So day one, when she walks in the door to me, I tell her, well, with 8 out of 10 severity of period pain, and you never had a laparoscopy, you have these fertility problems, you've got endometriosis until proven otherwise. And on one level, that's not rocket science. My teachers could tell her that, but it was a revelation to her. And then the challenge is, if you go to the wrong surgeon, they won't identify the endometriosis properly, or if they try to surgically treat it, they won't do a good job. So there's a real problem in the world of gynecological surgeons that only a small number are appropriately trained to deal with endometriosis. So thankfully, we have an excellent surgeon in Ireland. I referred to that direction straight away, and he found significant deep infiltrating endometriosis, stage 3, and it needed surgical correction. So he corrected all of that. We complemented it with all of our usual treatments, and we were able to prove by ultrasound, her fertility app, and her bloods, we got everything right. And then we had to wait for conception to occur. And as it turned out, we didn't get her to conceive until her 12th balanced cycle after the surgery. And this is where I often tell people, don't give up. And it's really, really hard on the physician as well as the couple when it's not happening as quick as we want. Most people will get their pregnancy between cycles 5 and 8. Some, it'll be the first 4 cycles, and others need to be patient. And then when I tell people, as we're approaching our 12 cycles, I say, well, that's a soft, suggested, flexible stop date. We can go 4 months beyond it for those who want to. They decided they'd like to do 4 beyond it before we'd finally draw a line under it. But as it turned out, it was the 12th cycle. We finally got our positive test. And as a testament was persisting, and thankfully they had a beautiful, successful pregnancy. They had a history of 8 years of infertility and all those failed IVF cycles. And finally we got a lovely full-term, normal weight, healthy mum, healthy baby, because we watch her hormones throughout. Now, after she had her baby, she was planning on coming back again. She was breastfeeding and she was getting ready, getting used to the little one. And she had all her plans ready to come back. Spontaneous conception, no medications at all. So that's the beauty of restorative reproductive medicine. Because of surgically excising her stage 3 endometriosis and correcting everything, there is a momentum that carries us something very positive about being pregnant that helps you to get pregnant subsequently. And we find 20-25% of couples will have a repeat successful pregnancy with no intervention, sometimes despite really difficult histories.
Isn't that amazing? Yeah, when you were sharing that, I just kept thinking of what you said earlier about malpractice. I mean, that IVF clinic should be sued. I mean, that's just horrible. It's absolutely horrible. How do you not ask a female about your cycle pattern before you're doing that? Are you having heavy, tell me about your periods, tell me about this, like just basic medical history before you're about to pump her full. I mean, the hormone regimen for IVF is just insane, what I hear that women put their bodies through. So wow, that is amazing. What an amazing story. It's so interesting when also when you said that then they spontaneously just naturally got pregnant without any intervention because the body is working as it should now, and they engaged in intercourse when they were fertile. My favorite professor as an undergraduate, I was majoring in special education, and she told us that the purpose of our job was to work ourselves out of a job. We had to do our job so well and support general ed teachers and our students so to such a great extent that they then had all the skills they needed to be without us, and we could go on to the next case and take care of that and then let it go. So she said, and I just loved that. It was so empowering to be like, okay, if I do my job well, I won't have a job. And I feel like that's kind of the same in this situation, right? Like if you do your job well, like the couple doesn't really need you anymore. They just do it the way that they're supposed to do it and it all works. And it's so freeing. The irony of it though, right, is like, well, then you're on to the next case. So like doesn't seem like you're ever going to be out of the job. But if you work with that mentality, it's also a humble state to kind of be in, recognizing that, the body just needs to help getting working as it should. And then we just let it go. We don't have to be there. Whereas an IVF, IUI kind of approach is like, now you're creating a crutch, like, well, now you need me because I'm the one that's doing it instead of your body doing it. Does that make sense?
It does, yeah.
Okay, so let's talk. You mentioned a little bit. I want to make sure we highlight the app because I really, really like the Neo Fertility app a lot. The Chart Neo. I used it actually when I was teaching a class, an elective for undergraduate students about charting the cycle, and because there's one of the some of our audience, our listeners, are moms. And so a lot of them are moms, but we talk about mothers and daughters and helping them teach their daughters how to do this. And the Chart Neo app, correct me if I'm wrong, Dr. Boyle, has like a toggle on it where you can basically say like, this is not intercourse related. This is just like for health monitoring. So why don't you tell us a little bit more about the app and where we can get it?
Yeah, so simply chartneo.com is our website, and if you just put in Chart Neo into the app store, you'll be able to find the app. But the attraction with this is that it is developed in particular for Neo Fertility, and we have our own code, we have our own stamping, the stamps that we put down, and our own process of teaching. But we also have this caveat where it has a degree of universality to it. So if you're trained with Billings, you can actually toggle it to demonstrate Billings stamps, and you can just work with mucus on its own. You don't have to use urinary hormones or temperature if you'd rather not. So we can give it that Billings look. We can also make it look like a FEM chart. We can make it look like any of the symptothermals. So there's various different systems, and they can change the stamps to make it what they're used to looking at. We can also do it as a PDF so that you can print off your paper charts to bring it to your doc. If they're not working with the Chart Neo, you can print off your charts, all the details clearly printed of your medications, your blood test results, your ultrasound. So it puts everything in one place that's really easy to access. We've gone with there's official medical criteria to diagnose PMDD, premenstrual dysphoric disorder. It's a severe form of PMS, and we've taken all those criteria and we put those down as the symptoms that women would record so that we can concretely diagnose PMDD, and then we can look at the impact of our interventions to see can we cause that to improve with our interventions. It is intuitive, and we do have teachers, and a lot of our teachers, they would say, well, look, I'm a teacher working with Chart Neo, but I've trained in FEM or Billings or whatever method they've trained in, and then we've a smaller number that we've actually trained ourselves. So there's a mixture of teachers, but each teacher you can see which method they've actually trained in. So that's about it, I think, in a nutshell. Oh yeah, we are in the process of developing teaching tutorials that we're going to put in the app, because we find a huge number of people just don't go to their teacher, or they get stuck with some aspects of it and say, well, we're going to make these videos available so that you can receive key points of instruction that really help you to get the most out of your app. Now, we have yet to conduct a use effectiveness study, and we're quite ambitious to do that, to demonstrate its effectiveness for fertility awareness and family planning. We recognise we're standing on the shoulders of giants, of people who've done the basic work through Billings, Creighton, symptothermal, and identify that fertile window. But incredibly, of all the methods, Marguerite Duane and her research group showed that we don't yet have a highly effective, use-effective study. We don't have a high-quality use effective study completed, but they're all of moderate quality. Well, we would like to meet that goal and develop a high quality use effectiveness study and see what our success rate is to help couples who want to avoid conceiving. One of the challenges when it comes to doing a use effectiveness study is people change their mind halfway through. They see it's a fertile day and they knowingly use it, but they've been categorized as avoiders when in fact they've changed their mind. Whereas we'll have a thing pop up and it'll recognize, oh yeah, I've changed my mind. I know it's a fertile day, but I'm now knowingly using that, and we'll see what happens. And that's real important for a use effectiveness study, to get real-time updates like that. But it's something that's evolving the whole time, and AJ is our technical developer of all of this, and he's a real passion for it. Himself and his wife have used NFP for years, and he's got a real passion for this work, and he's applied the technology, and he's done it in a really, really good way. So I'm enthusiastic about it.
Yeah, that's fantastic. I'll link to the app and the Neofertility website in the show notes for those of you that want to check those sources out. But I'm so glad you brought that up, Dr. Boyle, because that was what I was thinking when you said high quality. I'm like, oh, are they going to ask day by day, what's your intention in this act? Because you're right, that for those of you that maybe aren't familiar with, kind of research or the understanding of how, when we get studies and the CDC publishes, here's the effectiveness rate for fertility awareness methods. One, as we've talked about before, I think Emily and I, didn't we do an episode on that chart in particular? Yeah, we did an episode on the CDC chart. But just as kind of a reminder, that number lumps anything in there. So anyone who categorizes what they're doing as like NFP or fertility awareness. So it doesn't differentiate a method, an approach, and it does not highlight your intention switch, which, as you pointed out, Dr. Boyle, can happen. Just like it could happen with someone who's using an artificial means, but they have to be more intentional, like deliberately stopping to take the pill or get an IUD removed, et cetera. Whereas this is a behavior-based method. So the beginning of the cycle, 3 weeks ago, when I wasn't fertile and I was on my period, we didn't want to get pregnant. 3 weeks later, I mean, it sounds like, oh, who changes their mind that fast? Like, it can totally happen. 3 weeks later, it says, oh, you know what? Yeah, I would kind of be open to it. If we got pregnant, that's totally fine. And so that would not have anything to do with the effectiveness of the method if they got pregnant during that cycle. But what Dr. Boyle is saying is right now, the studies don't account for that change, the intentional change of the couple. So that's fantastic to hear. Yeah, that would be so interesting to see the effectiveness use rate of those of a method like neofertility or any other fertility awareness based method.
Yeah, and then you have couples who are relaxed avoiders, where like you say, oh yeah, we're open to it, and then you have others who are serious avoiders, and they use it at a much different way. So we want that strength of intention as well. And you will, there always can be a surprise pregnancy rate with it. But we want to know, well, what is the true incidence of that? Because it's difficult to get really good data on that. But it's, these methods are more effective than a lot of the studies would suggest because of the flaws in the way the studies are designed as well.
Right. Oh, that's fantastic. Yeah, that's so exciting. Okay, so definitely go check out the app. I just as like a user, the way that they have it formatted, it's just really very user friendly.
And the only thing, sorry to cut across, but remember, we don't sell your data to anybody. So a lot of these free apps, you are the product, and it's your data it can be sold on, and you really have to look at that. Whereas we say, no, that's why, there's a cost to running all of this. And that's why we have to charge, I don't know what the fee is it $20 a year? So there is a fee to it, but that's because it's we need that just to run the whole thing anyway. So just to be aware of the data security, I think that's real important.
It is, yes. Thank you for highlighting that again. And you did mention that people can learn to chart with Chart Neo. And is that through the website as well? They can find a teacher?
So the teachers are there, and there's no question there are people who wing it. And when I would see couples who come here and they haven't been to a teacher, I really struggle. And we're at the point where 2 or 3 sessions with the teacher, you're well up and running with this. So you can learn it because it is quite intuitive to get up to speed with it. And we find that's as much as what most people would need. And then there's a few exceptions who would need more. But it's a good investment, I think, to work with a teacher. But there's still a number of people who just won't make that investment. And our hope is, well, if we've education materials built into the app, we expect that's coming within the next 6 months, then they can access that and get key information to make it a more effective system for them.
Now, how about the NFP teachers that are already out there and they're listening and they think, you know what, I wouldn't mind learning how to teach this or adding this to kind of my resume and services I offer couples. What kind of training do you offer them?
So at the moment, because we're putting some more educational materials into the app, we're going to see, well, what is the role of the teacher? It's going to change a little bit. So it's a little bit like this threat of, is AI going to take all of our jobs? And say, well, we'll have some AI, so to speak, built into it. But you always need that personal touch, and you need somebody to inspire your confidence, a real person you can talk to as well. So I think the role of the teacher is going to change. It won't be as much emphasis on, for example, when you work with our app, the app, if you put in your observations correctly, the app puts in the code for you and picks out the stamp and picks out your peak day. Whereas if you're working with paper, you have to think about, what is the code I put in? What is the stamp? How do I pick out my peak date? That's all done for you already in the app. So the emphasis is on how do you make good observations and how do you develop healthy habits in a consistent way that is not overburdensome, but very reliable at the same time. So that's where our goal is moving more in that direction. I got distracted now. I forget what I was saying.
The teacher, just the training of people who want to help teach.
So our teachers, their role will be different. And my vision for teachers will be, they'll have fewer sessions with couples. There'll be shorter sessions. And our hope is they'll be teaching much bigger numbers. So they'll still have that important role, but it's going to change. That's how we'd see it going. Yeah.
So we'll become more efficient and be able to, meet more people where they're at. Nice. Okay, great. Emily, do you have any questions? Anything? Okay. I didn't want to.
No, this has been great. No,
I know.
So great.
So helpful. And so let's start to wrap up a little bit here. I don't want to monopolize too much more of your time, Dr. Boyle. Thank you for being with us again. This probably is an obvious answer, and I think I already kind of know the answer, but for people who are listening who might think like, would I qualify for neofertility? Do you think this might help me? Who could this help? Who could charting and working with a trained professional like yourself help?
So, so being based in the US, I would go to the chartneo.com to find out where the doctors are based, because they're listed on our app there as well. And we've different levels for the doctors. So the first is, to find a doctor who could potentially work with them. That's where they would find them. And then the people that we can't help would be cases of very severe male factor. Now, what's interesting is, with regard to male factor, you'll find in the CDC data, 27% of couples going for IVF, there's male factor for the reason why they're going for IVF. But if you look at the semen analysis results, there's only 1% would be in the bracket that it's beyond our ability to help. The other 26% we could work with. So it's only, and they have some aspect that's just a little bit suboptimal. So the idea would be, if you've any doubt about it, find out who the doc is that you'll work with, send them a copy of what the male result is like. They can look at it and let you know if they could work with it or not. But in broad terms, if the count is below 1 million, that's usually improbable and unlikely, even though we've a few notable exceptions where it's a little bit below the 1 million mark and we can still get there, because the count is meant to be up at 16 million. So, but a lot of male factor who are told you need IVF, that's not true. And then there's another interesting bracket where if you've blocked fallopian tubes and both tubes are blocked despite attempts at surgical reconstruction, well, then we're in trouble. We can't work with that. But it's uncommon that you'll find a woman with both fallopian tubes blocked. And if you do find a good restorative surgeon, they can often restore patency to at least one tube, and that's still an option. But if both tubes are blocked despite surgery, then we can't help. I used to say, if you enter the menopause, then you're beyond our ability to help. But that's not entirely true anymore. So there's a blood test you do for, it's called FSH, your follicle stimulating hormone. And normally you've got about 10 or 12 units of that to get you ovulating. Well, and that's a blood test at the day 3 of your cycle. Well, as women get closer to the menopause, the FSH levels go up and up. And we used to say if it's above 30, it's too high. You're perimenopausal. We can't really work with this. but we have a system of reversing that. And if somebody, her FSH was 97, and with appropriate treatment, we got her levels back down to normal, and she had a successful pregnancy with us. So even women who are in the perimenopause, now the percentages will be lower in that group, but it's still possible and is still worth treating, whereby you can hopefully get pregnant with your own egg. Because a lot of our colleagues are immediately saying it's donor eggs, and that's a bridge too far and unacceptable for an awful lot of people. And there's still an option where you can conceive naturally, even in that case. So there's very, very few cases that are beyond our ability to treat at this stage. So the vast majority, if in doubt, they can always contact the doctor to know for sure. But there's very few, thankfully, that we can't really treat.
That is so encouraging, Dr. Boyle. Oh, that is so encouraging.
Yeah, very hopeful. And we always like to mention our young girl population, young females kind of coming up who maybe aren't in the years yet of looking to achieve a pregnancy. Maybe just talk a little bit, Dr. Boyle, because that is the population you work with. And one of the things that inspired Emily and I both is working with couples. They come to us late 20s, early 30s. They've been on the pill for 13 years. It's like the same story over and over again. They want to be pregnant yesterday. Now we got to go through this time of figuring out what's going on and correcting it, which is great. We want to do that. But it's like, wouldn't it have been great if like way back 13 or 14 years ago, you were never put on the pill and we just figured out what was wrong, got you ovulating healthy. So you had healthy ovulatory cycles. So Emily and I say that a lot in the podcast. Like, how can we just get girls ovulating, preserve healthy ovulation, and then through the whole of your reproductive life, we're getting that beautiful flow of hormones, all the good things it's doing for your body. And then during your time of years of trying to build your family, you can either achieve or avoid a pregnancy, but we can still preserve ovulation. Maybe just I'd love to hear you speak a little bit to the importance of that, regardless of your pregnancy intentions.
Sure. So your fertility cycle is a reflection of your general health. So women who are healthy will have a healthy fertility cycle. Women who are unhealthy have a cycle pattern that is not optimal. Intense period pain, long irregular cycles, abnormal bleeding, and these things do need to be treated. But the problem is most physicians will put a woman on the pill and say, no cycle, no problem. And it'll lessen the period pain, it'll get rid of abnormal bleeding, it'll regulate the cycle where you get a monthly bleed as a result of the hormone changes, but it's actually suppressed the underlying problem and hasn't dealt with it. And then you get the side effects of the pill. So women who have not been pregnant before and they're on hormonal contraception for 4 or more years before having their first baby, their lifetime risk of breast cancer goes up every year they're on the pill. So you're increasing her lifetime risk of breast cancer, you're suppressing her ovulation. And if you've controlled your period pain, say, well, it's going to stop my endometriosis, right? No. So they've looked at the data, and if you suppress ovulation with hormonal contraception, endometriosis will continue to spread. It doesn't stop it. So it does mask the symptoms that are there. And our view would be, well, get to the underlying root cause behind it. One of the medications we have that's very useful is simply natural progesterone to regulate your cycle when you've got long irregular cycles. But you can also regulate it with diet, exercise, and non-prescription over-the-counter myo-inositol. And you'll find a lot of women with PCOS will clinically feel a whole lot better with diet, exercise, a low-carb diet, appropriate exercise, simple supplements, and myo-inositol. So often if they see a doctor who can implement this restorative strategy, they can track their cycle and they can see how well it's responding to the different interventions. And then there's low-dose naltrexone, which most restorative doctors are very familiar with. It reduces inflammation and reduces period pain, reduces premenstrual symptoms. And if that isn't doing it, then there's this debate among the endometriosis surgeons. Is it wise to intervene proactively and excise the endometriosis when you're younger, or should you leave that till you're actively trying to get pregnant? So that hasn't been fully teased out, except Dr. Patrick Young, who's a surgeon in St. Louis. He's published a good paper for women in their late teens, early 20s. If they have severe period pain, he looked at a group of 20 of them, 17 out of 20 had endometriosis. He excised it and he cut it out in an appropriate way, and he was able to eradicate their endometriosis. And that can stop chronic long-term inflammation. And when you have that inflammation, you just don't feel and function right. So that'd be my preference, even though I know there's debate among surgeons, that I'd be more proactive surgically. And ultimately, endometriosis is more of a surgical issue, but you gotta find the right surgeon who's going to do the right job. And the issue is the reimbursement in the United States is an issue, because if a doctor does a 20-minute surgery or a 4-hour surgery, they get paid the same. So there's a real issue around that the surgeons are wrestling with. But that'd be it in a nutshell. So there's just this idea that you, for example, in my training as a family physician, we're told if a woman of childbearing age who's single comes into you with an ingrown toenail, put her on the pill, because you want to prevent unwanted pregnancies. And you're just proactively putting women on the pill all the time. So, and often you have a short consultation as a family physician, and you're very quick to prescribe and issue the prescription, but it's like, there's consequences to it. That's not an approach I would agree with at all. I think there's a much better way of going about it, and empowering women and treasuring their cycle and all that goes with it. There's a whole philosophical view regarding sexual activity then, and all that goes with it. And obviously we come from a Catholic point of view and say you leave sex until you're married. But if you're not married and somebody wants to use this from a family planning perspective, it will be as effective as the pill. But is it really the right decision for you? And it really changes things when there's always a possibility you may have a surprise pregnancy, because the pill disconnects that, whereas we keep it connected and say, are you sure you're open to a surprise pregnancy? Because there's no method, including hormonal contraception, that's a guarantee. And then that really helps to connect it and say, this is about babies, it's not just about the pleasure, and it's a really healthy thing, and more integrated for the woman.
Yeah, I completely agree. I think that's one of the benefits of helping our young girls understand their bodies more. I think almost, again, without being too overt, kind of covertly, you're sharing with them like, look, this is how your cycle works. You have times of fertility and infertility. And then as you're looking to the outside for partners, you're looking for someone who's going to respect those times of fertility and infertility. How well do I respect them? How well does he respect them? Therefore, how well does he respect me? Et cetera, et cetera. It's like all these kind of messages that you just start to get and pick up on without them ever even really being spoken. To your point, Emily, like the language of the body that you mentioned earlier, how much that speaks to the other person too. Okay, great. So yes, we want young girls to be ovulating, healthy. Maybe there's still some debate with, should we have the surgery earlier for younger girls that are in severe pain with their periods? But that would be something you want to talk with your medical professional about. But at least just something for moms to kind of keep in mind. This is a great time to help our girls find the root cause answers to their issues to set them up for healthy cycles. So I don't think I have anything else. Emily, do you?
Well, I have a question. So you're in Ireland, and so a lot of our are in the United States. So where would you tell them to go to try to get connected to somebody in the States?
I'd go to chartneo.com, and the teachers and the doctors are listed there. So that would be their best bet if they need any support. Yeah.
Perfect. Thank you.
Unfortunately, I can't treat anybody in the United States. So my medical cover only allows me to treat people in Ireland and the UK. So it wasn't always like that. I've treated people from all over the world and had great fun doing it, actually. But unfortunately, even though communication has got better, the malpractice requirements have got more stringent. I think it's similar in the States, where doctors can only prescribe and practice within particular states now as well. So I don't know why that is, but anyway, that's the nature of it. Yeah.
Thank you. So much. Yeah. Thank you so much, Dr. Boyle. And so we'll link to all those sources that he mentioned with ChartNeo and Neo Fertility in the show notes for anyone that's interested in reaching out and getting some more information. Thank you again for your time, Dr. Boyle. I know this is going to be very helpful for a lot of people. And we'll be keeping you in your prayers. And thank you for all the great work you're doing to help restore fertility and help women and couples be as healthy as they can and bring babies into the world. Is such a beautiful gift.
Thank you.
Yeah.
Thank you both. Yeah. Keep up the good work you're doing as well. Thank you.
Thank you, Dr. Boyle. All right, guys. Well, we will see you in the next episode. Bye.
Bye.
That wraps up another episode of the NFP Podcast. Thank you so much for joining us today. We hope you found our discussion enlightening and empowering. Don't forget to subscribe so you never miss an episode. We'd love to hear from you. Please connect with us by sending us an email with your questions and stories to thenfpshow@gmail.com. We'll be back next week with more insights, tips, and heartfelt conversations about natural family planning. Until then, love responsibly.